All right. Good to see everybody today, and thanks so much for inviting me to present. And so I'm going to be talking a bit about sleep problems in the menopausal transition, and really informed by my years of practicing behavioral sleep medicine and seeing all the changes in how women's health how women in the menopause transition have been treated over the years, over the last 20 years. And so going into this talk, it's important to recognize that sleep in the menopausal transition time is not just about the hormones. You can see that this is a review from Dr. Mackey, and you can see it's at the center of this Venn diagram. But one of the biggest factor in sleep really is the hot flash symptoms. But in addition, the sleep disturbances are both overlapping and separate. The women have sleep problems that are also due to many other factors. And then there are also mood changes that are some related to hormonal changes and some outside as well. And then all of these things are happening in the context of other medical conditions and psychosocial stressors, relationships, work, etc. One of my favorite positions that I had was working in a midlife women's clinic, one day a week doing sleep consults. And the most wonderful thing was it was like set up like a spa. It was like there was like waterfalls. Like I felt so good going in there. And the OBGYN and nurse practitioner who ran this had physical therapists, psychologists. And when women came to this clinic, they were coming in largely due to their hot flashes, but actually they had so many healthcare needs at that time in their life that had been really gone unnoticed or undiagnosed, untreated. And so they were like, well, while you're here, do you want to talk about your sleep? Do you need some pelvic floor physical therapy? Do you need this? Do you need therapy? Like, it was such a wonderful time to work there because it was really a opportunity to improve women's health and their lives overall. And so when we talk about sleep in this transition time, it's not just about the hormones. That women are not getting a good night's sleep. 60% they only get a good night's sleep. 60% say they only get a good night's sleep a few nights a week or less. And maybe you can see yourself in this category. But women are sacrificing their sleep and other things to get things done in their life. So when women were asked in this survey, what do when you're tired or run out of time in the day, what do you give up? Number one, they said they give up sleep, but they also sacrifice exercise, time with friends, healthy eating, sexual activity. Only 20% said that they sacrifice work. Like, did I answer these questions? I think that lineup is pretty accurate. But that women are sacrificing sleep and other wellness activities due to lack of time. And then, more specifically to sleep in the menopause transition, let me see if I can move this. But there's been several longitudinal studies looking at how sleep changes across the menopausal transition. And this one in particular, it was really well suited to look. It took women from perimenopausal to postmenopausal. It also had a sample of surgically menopausal women. This was a study of women in midlife, the SWAN study, that studied over 3,000 women at several sites in the United States. And what they found was that sleep problems, as you would expect, increased over the menopausal transition, and the greatest increase was in difficulty maintaining sleep. That this striped bar. But importantly, they increased most sharply from early to late perimenopause, but they also remained relatively elevated even in the postmenopausal period. It's also important to notice that the surgically menopausal women had the greatest sleep problems. And so one of the goals of the study was to look at hormonally, what's the predictor of these sleep changes? And I'd say they didn't find a smoking gun. Probably it wasn't one hormone, it wasn't one thing, but if they had to pin it on anything, it was this rate of decline in estradiol that was the biggest predictor of their change in sleep. And unsurprisingly, hot flashes were quite prominent. There are 80% of women during the menopausal transition, and the hot flashes were the greatest predictor of sleep problems. But it's also important to note that it wasn't the hot flashes as much as it's the hot flash distress. So that there's a difference between the presence of having them and how frequently you have them and how much they bother you. So people who have them frequently and or more bothered are the ones who had the most sleep problems. And there's a whole lot of really cool experimental lab studies about hot flashes and sleep where they look at what time, like with a thermal monitor, like what time the hot flash happens and when the awakening happens. And kind of cool thing happens the first half of the night, the hot flash precedes the awakening, and the second half of the night, the awakening precedes the hot flash. And so it's thought perhaps that there's sort of like a sensitization that happens to women, that it's just these frequent awakenings that kind of make them more arousable in the night. Awakeable is not a word. So in terms of treatment recommendations, I want to talk about a couple different areas. First, in terms of the first and foremost goal would be treating the hot flash and hot flash distress, but also assessing for sleep disorders. And again, looking at this in the context of psychosocial stress and other behaviors such as diet and exercise, which you've talked about already today. Okay, this is a really puny slide about hormone replacement therapy and sleep. This has probably been covered at other points today, but the biggest thing is that it's not a panacea in terms of sleep. There's mixed results overall, whether you're looking at does hormone replacement therapy treat sleep apnea or will it treat insomnia? Mixed overall, but it's really thought to be for insomnia most effective in those who are having hot flashes, which would make sense. And this is a good review by Tarian et al. There's probably a more recent one as well. I've been in the field long enough to see in the time when women were afraid to take hormone replacement therapy, and like overnight to have women come in and say, I can't sleep, I just need it back, and so really to see the pendulum shift when women were really suddenly taken off their HRT, it caused a lot of sleep difficulties, and a lot of them showed up in my clinic. So in terms of insomnia disorder, it's in the DSM and the ICSD-3, which is the Sleep Disorders Diagnostic Manual. Insomnia is defined as difficulty initiating, maintaining sleep, or early morning awakenings. If it happens 3 times a month for at least 3 months, it's considered chronic insomnia. You also have to have adequate opportunity for sleep. So if you're just not going to bed, that's not insomnia. Cognitive behavioral therapy, CBTI, is the gold standard treatment for insomnia. It's recommended by all major medical and professional organizations as the first-line treatment. It's multi-component, meaning that it involves different techniques that are given week by week, generally by a clinical psychologist, although other professionals have been trained, but it is by a trained mental health practitioner. And not all psychologists are trained to do it. So the biggest challenge, I would say, with cognitive behavioral therapy or CBTI is that there aren't enough practitioners to do it. Probably 800 worldwide are trained to do this treatment. Now, there are books and online programs and all kinds of things, but getting this technique is really difficult, even though it is a gold standard. So CBTI is highly effective at improving time to fall asleep, quality of sleep, reducing awakenings during the night, improving the efficiency of sleep, and increasing the total sleep time. But it's important to know it takes 8 to 12 weeks to go through a program like this. So not everybody's got the time. Remember, I just said women don't have enough time. It's not a quick fix. They have to come week after week, and you have to intentionally do things that make your sleep a little worse to make it better. Like, don't get up at the same time even if you didn't sleep, or get up in the middle of the night. If you wake up, get up and read. And then also, it's not intuitive, so it's hard for people to do this on their own. If they read a book, they really need a therapist. They need me to look at their log after a week or two and say, I know you're more tired, but things are changing in the right direction. Hang in there. So CBTI for menopause-related insomnia has been studied in several studies. This is a study by Sue McCurry and colleagues that was published in 2016, and they compared 8 weeks of CBTI to menopause education sessions. And what they found was that there was a significant improvement in sleep in the insomnia CBTI group. And in fact, it was about 80%, and you can see that bar there at week 24, 80% of women in the insomnia group, in the CBTI group, did not have insomnia anymore, compared to only about 40% in the menopause education group. But what is the coolest thing is that in the CBTI group, they actually had a decrease in their hot flash distress. And so it wasn't just an improvement in their sleep, it was improvement in their menopause-related symptoms, whereas they didn't see the same improvement in the menopause education. And in fact, the groups had an equal number of hot flashes. The frequency of hot flashes was the same, but the stress over it improved, which is very cool. So less interference from hot flashes in their life. And then this is a very busy slide, but it was a secondary analysis of all these studies in the MIS-FLASH trial where they looked at all these different treatments' effect on menopause-related quality of life. And so if you can look for the kind of magenta bar, that CBTI performed as well as estradiol, which is it's the turquoise bar, in their menopause-related quality of life. And then which also, there were improvement in all the groups, but you can see that it outperformed antidepressants, exercise, and omega-3. So CBTI, addressing the sleep symptom itself, improves people's menopause-related quality of life if they're having insomnia symptoms. So in terms of what's new, CBTI has been out for 30 years, but I still talk about it every talk because it's the #1 gold standard treatment, and it's the most effective. Now, in terms of what's new in women's health, the newest thing I'd say for insomnia would be the approval of a new class of medication for insomnia. So these are the FDA-approved medication for insomnia. At the top, you have the benzodiazepines. Second group is a non-benzodiazepine receptor agonist. There's melatonin receptor agonist, tricyclic antidepressants. And then the last one is the newest approved, which is the dual orexin receptor agonist. Now, those three medications, suvorexant, lemborexant, and diurexant, have recently been approved. In terms of, they have efficacy data to show that they improve sleep. And there is some talk that perhaps they might be unscheduled at some point, which would be an advantage. Now, an important thing while we're talking about FDA-approved medications is that zolpidem was actually the first medication that had a sex-based prescribing. So that they originally approved it for up to 10 milligrams for zolpidem, and then they said in 2006, I believe, oh, women should be on 5 milligrams. And again, my doors were flooded in with women saying, my doctor cut my medication dose in half and now I can't sleep. And so it's really interesting. It was in their original FDA application that women processed and they metabolized the medication slower, and then they came back and said, we're changing the dosing, which is very interesting. So, in terms of sex differences in the newer dual orexin receptor agonists, there are no known sex differences at this time of, their efficacy or their processing. So other disorder I want to talk about today is sleep apnea. Sleep apnea increases steeply post-menopause. And there's several different contributors, including age, change in fat distribution. So as adipose becomes more central and less peripheral, that also increases your risk for sleep apnea, as well as hormonal changes. As most of you know, the main treatment for sleep apnea is continuous positive airway pressure. But I don't want women to be afraid to go to a clinic and get assessed, because this isn't the only treatment. The treatment should be focused on the severity as well as the preference of the patient. And so, for example, mandibular advancement devices, they're dental appliances made by a dentist that can titrate them and study them both, study the person pre and post, can significantly improve sleep apnea, as well as weight loss can improve sleep apnea as well. And so women, unlike men, women oftentimes don't snore when they have sleep apnea. They say things like, I feel tired, and they often feel depressed, or maybe feel like their sleep quality is poor. What does that sound like to you? That sounds like a lot of things. And so women often go misdiagnosed for a long time, and their sleep apnea doesn't get diagnosed for a long time until they finally find their way into a sleep clinic. So in terms of new treatment options, first of all, I want to talk about the hypoglossal nerve stimulator. It's an implantable device, and before somebody has this treatment, they have to show that they failed CPAP. So this is for people who can't tolerate CPAP only, and they have a sleep endoscopy to look at the place where their airway closes. And so basically it just makes them stick out their tongue and open up their airway. And this treatment has long-term, now 10-year efficacy data. I have a story of a patient I saw for insomnia for many years, and her insomnia improved, but she still didn't feel good. She got depression treatment. She exercised. I mean, she did everything. She was a 50-year-old thin woman, active, and she just said, I don't feel right. And finally, she had a sleep study. She tried CPAP. She couldn't tolerate it. She finally had a hypoglossal nerve stimulator, and she felt really good for the first time, which was a really amazing outcome. The other thing recently improved are weight loss medications. Tirzepatide is now approved for the treatment of sleep apnea. And again, there's no known sex differences there's sex differences in sleep apnea severity, but there's no sex differences in the outcomes of the data to this point. And then last, I never want to finish up a lecture without just giving out some sleep advice. I can't help myself. But, if you're having trouble sleeping, you do need to think about making sleep a priority in your life, making enough time in your schedule to have at least 8 hours in bed so you can get at least 7 hours of sleep. If you're having trouble sleeping, though, you should wait until you feel drowsy to get into bed. You should get out of bed and read for a few minutes if you're not falling asleep. Get up at the same time each morning, 7 days a week. Of course, manage stress, exercise, and then seek treatment for sleep disorders. And there's all kinds of self-help guides. This is one I particularly like called Quiet Your Mind and Get to Sleep, because, wouldn't we all like to do that? And then we have an upcoming study I just want to give a shout out to. This was recently funded by the Patient-Centered Outcomes Research Institute, or PCORI. It's a multi-site study of 5 sites in the U.S. It will be recruiting 891 women that are perimenopausal to 5 years postmenopausal with insomnia symptoms. And they'll have a 12-month follow-up. And so there'll be 3 in-person visits, I believe, and they'll be randomized to either a digital CBTI, trazodone, which you notice is not in the FDA-approved list, although it is very commonly used, and then diurexant, which is one of the newer approved medications that perhaps could have a better safety profile. And so we will be enrolling for this, and I will get the word out once we start recruiting. But if it's any indication based on people I talk to in my daily life about this study, I think that a lot of women are going to be interested in getting treatment for their sleep problems. So in summary, I hope I've convinced you that sleep problems in the menopause transition are multifactorial. It's important to address hot flashes, mood disorders, and behavioral contributors. And then in your patients, whatever clinic you are, don't forget to screen and treat sleep disorders, because they can have they can make a difference in quality of life down the road. So thank you very much.
Any questions?
Yes, I mean, restless legs. First of all, women have much more frequent restless legs than men across the lifespan. I actually don't know whether it increases with age. I did a quick search on it for this. Certainly I know in pregnancy, restless legs increases quite substantially. What do you know about restless legs? Do you know? Yeah, it's actually my next one. Yeah. Mhm. So being that I'm a clinical psychologist, I, you know, I would say that, I'm not involved in the medication or hormone replacement side of things. And I'd say when we were working on this PCORI proposal, one of the questions that we got often was like, should we consider HRT in our group? Should that be a group? And I would say the majority of patients that I see it's not something that they're thinking about or have considered. Perhaps it's picking up, but in terms of societal um, interest or preference, I think things are changing. But for a long time, people were afraid to try HRT for their, for try to overall. And one of the reasons we decided also against it in our study was that primary care providers are not comfortable to use these. In our surveys, said that they were not comfortable. So my experience is pretty scant, I would say. Okay, great. Thank you.
Dr. Barron, I do have a question about magnesium. What are your thoughts about magnesium supplements that people are taking for sleep specifically?
So, I mean, it's one of those things that almost everybody has tried before they come to see me. Kind of like melatonin. They've always tried that before they come to see me. The data on magnesium for restless legs are not great. It's not super strong, in my opinion, in my read of the data. It doesn't, restless legs has the most placebo/folk treatments of any disorder. The ivory soap underneath the sheet. Like there is a strong psychological component to the feeling that your legs are twitching and that sort of thing. So the placebo, like the double-blinded placebo-controlled trials are not all positive. It's not a strong signal, in my opinion, but it's also something that's unlikely to harm them, unless they take too much and get diarrhea, and then it would be uncomfortable and unpleasant, but not harmful, So it's like one of those things that it's not something that I recommend. But by the time they come to see me, it usually takes maybe 9 months to get into my clinic. So they've really tried everything on their own before they come to see me. Thank you.
So our whole next section is going to be dealing with hormonal replacement and hormonal care. And there is no one better than Dr. Kirtley Parker-Jones, who's a professor emerita here at the University of Utah, who spent most of your career studying women and hormones. So I'm going to turn it over to you.